Okay, awesome. Hi, doctor. Good evening. How are you?
Hi, good evening. I'm good, thank you. How are you?
Fine, thank you. It's so nice to see you. Thank you for joining us.
Thank you for having me here.
Yeah, and I'm really excited to tell everyone that you're doing your first Instagram live with us. So,
Right.
yes, okay.
So no tough questions.
Okay, yes, doctor, of course. So, first of all, good evening, everyone. Thank you for joining in. I'm so thrilled and happy to invite Dr. Chengappa here today. He's with us. And when I requested Dr. Chengappa if he would be okay doing this live with us, he, as always, has given us a thumbs up for anything patient advocacy and patient education. So one of the biggest concerns I've seen is, of course, when it comes to skin and lupus. Like, it can affect any organ in the body. Similarly, skin is one of the most obvious manifestations of lupus. And so, some of us have seen that some of us have lupus rashes that have been transient and they've gone. Some of them have come. Some of them have like continued to stay. The scarring has stayed. Like, I have some in my ears, etc., that have stayed. And through this journey with Lupus Trust India, I've learned that many of us have had some sort of deep scarring that has actually not gone, and it still continues to haunt many of us here. And so that's how we decided to actually talk about uh, lupus and skin, and what are the two kinds of diagnosis, etc. So, doctor, over to you.
Yeah, great point, Vachas. It's actually good that skin is involved so often in lupus. That gives us the very easy window of opportunity to diagnose early. Had it been something internal that was going on for long without being detected, we would have missed a lot of people with lupus ending up with kidney failures. So this is, in a way, good. It's a positive thing, though it's not a very pleasant thing. So having said this, about 60 to 80% of them present with skin lesions of some kind, some mild, as you rightly said, some really bad. Scientifically, if we see, are divided types. One is lupus specific rash and lupus non-specific rash. Yeah, are you there?
Yes, I'm here.
Yeah.
I'm here. I just
So
put myself
it's
on mute to.
yeah.
Yeah.
So it's lupus specific and lupus non-specific rash. And in lupus specific rash, we have mainly three types, but two types are what that are commonly seen: acute rashes and chronic rashes. Acute, that comes fast and probably goes away fast. Chronic, that comes slowly, builds on and stays and lingers and damages. Yeah. Now I'm sure you know which is the commonest acute rash.
Which is the most commonest? Is it? Oh my God, I'm put under test. Is it the subcutaneous?
It's the
Oh, the
It's the
malar
butterfly
rash.
rash, mala
The
rash,
butterfly
common,
rash.
right?
Okay.
Yeah. So that is an acute rash. It
Right.
comes, it's photosensitive, it goes off. So there are a lot of rashes like this. Some are very dangerous, like 10 like lesions, bullous lupus. These are really dangerous. Yeah, see, Suzanne is right. So this is an acute rash. So it comes, it goes, it might stay for some time, irritates a lot. But there are chronic rashes like the discoid lupus rash, like the chilblain lupus. So a lot of named lupus rashes, lupus profundus, what we call. These are all chronic rashes, which is not so dramatic when it comes, usually. It can be. Uh, but it lingers on and lingers on and lingers on. Just because it's not so obvious and dramatic, we take extra time to approach a physician or a doctor. And that is the window of opportunity that is lost, where this chronic rash becomes a scar. And a classic example is a discoid lupus, which most of my lupus warriors would know, a DLE or a discoid lupus. So discoid lupus is a rash that is specific for SLE. Having said that, everybody with a discoid lupus need not develop SLE. Yeah. So people have seen, there are studies, there are cohorts of people with discoid lupus, and they have found that if there are multiple lesions above and below the neck, it's called generalized discoid lupus, then the chances of developing SLE or progressing into SLE is high. The second thing that could matter for progression to SLE is if somebody has a positive ANA, or if somebody has low white blood cell counts or low platelets along with this discoid rash, even then their chance of becoming a full-blown lupus over 5 years is a little high. So
Okay.
if you see anybody with only a discoid rash, a discoid lupus rash, about 5 to 15% may develop lupus over a period of 5 years. Okay.
Okay.
But if somebody has a risk factor that we already mentioned, like generalized discoid rash or multiple discoid rashes or positive ANA or something like that, then the risk goes up to 25%. Like if 100 people have all these risk factors, 25 of them will probably progress to lupus over 5 to 10 years.
Okay, that's
Yeah.
very new information for me, completely new. So, doctor, so you mentioned that DLE, that is, with patients with manifestation of discoid, have a, to just make sure I've gotten this right and that we all have gotten this right. Okay, I think there are already messages
Yeah,
coming
Priyambada
in.
already has the right question. So
Yeah.
discoid lupus, discoid LE is an entity in itself without SLE, without a systemic component. That is what we are discussing right now, Priyambada. So discoid lupus or DLE can just be a rash like anything else. But if those people have the above said risk factors, then their chance of developing lupus is high. Having said that, anybody with an SLE can have discoid lupus. About 30% of SLE in India will have discoid rash in them.
Okay, right, doctor. So, and you mentioned that the possibility of it uh, progressing. You use the word progressing to SLE is determined by the ANA factor of it, right? Okay, so does that mean that the possible progression can be prevented early on if you're able to catch
Mm,
on the discoid symptoms early on?
there's no data to support that. We don't know yet. Yeah,
Right.
but we can pick early, right? And the good news is most of the people who transition from a discoid to SLE, somebody who had a discoid rash over 3 or 4 years develops SLE, most of them are not severe lupus. They'll either have some arthritis, have some blood count abnormality, but major organs like brain, kidney are usually not involved. So that's a good thing.
Okay.
It could also be because it could also be because these patients or these individuals are already started on
Right.
hydroxychloroquine. So that
Okay.
might have been preventing. We don't know. This is just my hypothesis,
Okay.
but it is seen that these people who progress to SLE are not really severe lupus in terms of organ damage.
Okay, doctor. So thank you for clearing that. I know we wouldn't want to see skin as we have heard patients say this where I would have rather preferred an internal organ over discoid lupus happening to us. But I think, like you mentioned, no, that it's still any day better than having the internal organs affected. Instead, we're able to diagnose and pick on these early symptoms and treat better. So
Yes,
yeah.
there are a lot of options, right?
Yeah.
So once the internal organs start getting damaged, we don't have time, nor do we have so many options. Whereas if it is limited to skin, I understand that it is quite mm, I can say derailing from your daily life. It is quite also disturbing, but there are options. You can continue to explore. You have that time with you where you can explore. But once our kidney is starting to get involved, your time shrinks. You need to act fast. Everybody needs to act fast and control it. Yeah.
Right, doctor. Okay, doctor. So, to identify that it is DLE, of course, yeah, right. Sayuri is saying it affects confidence. You're
Yeah,
right.
definitely, definitely. 100%.
Right, doctor. And so I remember when I had I had different kind of rashes. The first thing we would do to is after a point. I think after identifying it's lupus is to get a biopsy, right? So the skin biopsy. Would do patients need to actually fear skin biopsies, and how frequently should it be done?
Question is, do we need a skin biopsy at all? First of
Yeah.
all, yeah. If it is a classic rash, we don't need a skin biopsy to prove it. Okay, because that is an additional start. I wouldn't want to do that. If it is a see, the skin biopsy would be required in a in a case of suspected lupus, where the rash mimics something like an infective etiology. You know, sometimes cutaneous tuberculosis can be like this. So we would want to do that. Or we want to diagnose if there is vasculitis going on. So these are the two main scenarios when we really would want to do a biopsy and prove things. Otherwise, in somebody with SLE, if they have a rash, even if it is not very typical, we don't go ahead and do a biopsy. We try and wait it. Having said that, skin biopsy is probably the easiest biopsy that we can do. And it is quite painless if we do it under general local anesthesia. It will also heal very fast because skin has got a very good blood supply. Yeah. And so it's probably a 5 to 10 minute procedure once the procedure starts. So there is nothing to be scared.
I think you're getting a call, doctor. Yeah, thought so. Yeah.
Be scared of a skin biopsy, but if your doctor insists on one, I think you should cooperate because that might give the doctor a very valuable piece of clue or information that might change the way you are being treated. So there's nothing to be scared of. It's probably the simplest biopsy as opposed to a kidney biopsy that generally happens in people with lupus.
Right. And I can also say that I have had it multiple times, and it is actually it was quite easy in comparison to the other
Yeah,
set
yeah,
that I've
yeah,
been through.
yeah. You
Yes,
can actually cooperate with the doctor, and you can also show the lesions, and you can also have fun and
exactly,
be part of the process
exactly.
in most of the.
Unlike a
Yeah,
kidney where you're
yeah,
lying on your
yeah,
abdomen, you don't know
yeah.
what's happening behind you.
Exactly.
And that's true.
Yeah.
Yes, yes, doctor. So, doctor, turns out Instagram has now come up with a new update like it does every single time. Now we can't share slides. So, I
Oh,
guess they
sure.
want
Not
us
a
to
problem.
interact more. But okay. So, doctor, to come to the next question. You mentioned that hydroxychloroquine is also used as a first line itself of treatment. What are the other set of treatments given for DLE?
So if it is only DLE without lupus, without systemic lupus, the topical treatment are the first choices. I would want to treat something by application or by local injection. So this usually falls into the domain of dermatologists, where they don't come to a rheumatologist generally. So what are our options? See, we have to understand DLE goes through three phases. A lesion, if you look at the life of a lesion, that lesion goes through three phases. One is an active phase, second is an intermediate phase, and third is a scarring phase. Yeah. So if every intervention to stop the lesion has to happen in the active phase and in the intermediate phase. Once it enters the scarring phase, it is more of a reconstructive procedure or a what we call as a rebuilding that place. That's it. Because it's all scarred and gone.
Right,
So
right.
in an active phase, what we see is a lot of redness, like any inflammation, because there is a lot of CD8 cells that are infiltrated into the lesion. It's a kind of T cell, and then there's a lot of scaling. Yeah, this is the sign that my DLE lesion is active, and this is the time you have to hit it hard. How do you it hard, you can apply topical steroid creams, which are highly potent, like clobetasol and so many things. And then you can also do a lot of injections into the lesion. You can put steroid injections into the lesion. Not you, by you I mean a dermatologist or a physician. So Lupus Trust India won't do that. So
Yeah.
so you can inject. That is an option we have. Okay. Once that this phase is over and it has got excellent response. If it is a solitary or two lesions, it has got excellent response by these two. But if it is a diffused lesion, then it makes more sense to take something orally, some systemic treatment. First line would always be hydroxychloroquine. Usually, the doctor would prescribe hydroxychloroquine. Very, very effective. The efficacy goes down if you're smoking. Today is World Tobacco Day, so I'll plug it in. So if you're exposed to smoking, your hydroxychloroquine efficacy goes down. Yeah.
Okay, doctor. Thank
Even
you.
passive smoking. Even passive smoking. Yeah. Okay.
Okay.
So
Okay.
that is one thing. Then we have other options like methotrexate, which is usually used for a skin and a joint component of SLE. Methotrexate works fantastically here. And in India, we don't have the biologics against interferons like anifrolumab, but there is another drug called thalidomide, quite toxic, but works very well for skin. Needs very, very, very close monitoring with your physician if you're being prescribed thalidomide. So these are the drugs, these are the medicines which we can take when the lesions are multiple. If it is both on your up above your neck and below your neck, which we call as a diffuse disease, then we'll have to take systemic therapy like this. So over, once this is over, it goes into an atrophic phase where, if you see properly, you will find very thin, shiny scars and lot of atrophy. Huh? The skin texture is lost. If there is hair, the hair follicles are lost. It's balding there, scarring there. And here is where a lot of reconstructive process happens. So
Okay.
amongst the reconstructive processes, it depends on how much you have and what is the access you have to these cosmetologists close by. One is, if it is in the hair, you can still try a hair transplant into that location. You can try a lot of pigment changing strategies like micro pigment changing strategies. So they can tattoo your skin color into the pigmentation areas instead of taking a lot of medications, because these are not going to recur there, right?
Right.
It's over. It's burnt out in that area. At least it is burnt out. Yeah,
Okay. Okay. That's very
yeah.
interesting. Right. Right.
And then you can also try laser therapy. There are pulse lasers, there are carbon dioxide lasers, which have got, even though a small case series, but excellent response. Up to 80 to 90% of them seem to be healing because of that.
So, doctor, in laser, I've also heard of the UV. No, is UV laser? There's one thing that they use, the same that's used for hair removal. Is that safe for us, or
I don't know.
gotten it
I don't
wrong?
know. I don't know about this,
Okay.
but we'll have to find out. Yeah.
Sure. Okay.
Yeah. I don't
Okay.
know about this. Yeah.
Okay. Okay.
So, there are some options. So, but having said this, there are some thumb rules that photo protection or sun protection is a must. If you do any of these, sun protection is a must, because the early inflammatory phase is usually triggered by ultraviolet rays, UVA and UVB rays. So, I don't think the UVA or UVB can be really used for a treating DLE. I don't think so. Yeah.
Okay. Okay, doctor. There was a very interesting question, which was, how do we distinguish DLE, in its initial stages, a
Yeah. Yeah.
DLE rash
Yeah.
from an HCQ pigmentation?
Oh, that is easy actually. The as I told you, DLE rash goes through these three phases. Whereas HCQ pigmentation is just because of HCQ.
But
There is
how does a patient know, doctor? Like, when do we catch on to a sign? Say it's in another part of the body altogether, and how do
right.
we How do we know that this should be told to our doctors in the beginning itself?
See, one of the thing is the color. The color,
Okay.
color of HCQ pigmentation is classically the gunpowder color. Firecrackers, that powder that remains in your hand, that is the color that is there
Yeah.
with HCQ. Yeah,
Yes.
we call it slate gray or whatever name, but it is the gunpowder color, and it is not going to be limited to one spot for sure. It
Okay.
has to be in multiple places. Yeah,
That's true.
yeah.
That's true.
It will
Local.
be on your face. Any photo exposed area, it is going to be there mostly. Yeah.
Sure, doctor.
And
Okay.
as we told, the DLE is going to go through these three phases. It is not going to start off with the pigmentation first. It is going to start off with some redness, some thickening, some scaling first. Whereas the HCQ pigment will be a pigment. It will be a patch there rather than a scaling lesion. So I think most of you who know DLE can definitely identify something else that is other than DLE, and definitely your doctor can tell them apart.
Right. I think the other lesson is that if we ever, even in any way, are suspicious or we're able to see some sort of a evident, rash here or somewhere else in the body, we really don't have to put the burden of us on us to figure it
Yeah,
out.
yeah, yeah.
We should be communicating that with our
One
rheumatologist,
hundred
and that would.
percent. Yeah.
Right, doctor. Doctor, you mentioned that DLE is usually, and if it's in the initial stages, it is treated by a dermatologist itself. But would you like, is that entirely a foolproof, solid uh, course of treatment? Wouldn't it be better for a DLE warrior to just directly go to a rheumatologist on day one?
It would be ideal, but given the scarcity of
Yes.
rheumatologists across most of the places, dermatologist is more accessible. Yeah. Rather than going to another physician, a dermatologist would do a better job. But if there is a rheumatologist and you know it is a DLE, then definitely that would be a better option. But having said this, most dermatologists these days will have a crosstalk. They would want to identify if there is systemic involvement, even 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 though it is little. So there is a crosstalk. There are some autoantibodies that are screened. The knowledge amongst dermatology colleagues have also improved a lot, and they are taking precautions to identify if it is systemic yet.
Okay.
So that way, it is good. But if you have an option of seeing a rheumatologist, definitely, especially if you have a multiple rashes. If it is a single DLE rash, you can still, be happy with
Oh.
dermatologist. But if it is multiple rashes, then definitely yes.
Okay, doctor. Okay, that's a very interesting point. That is,
Yeah.
when you say single, you mean like just one odd,
Yeah, one patch
one
around the lip.
localized.
These are very common.
Okay.
Around the lip, two, three patches, that's it. But if it is in multiple areas of the body, then for sure you should, see a rheumatologist because it will be associated with autoantibodies.
Okay, doctor. Since we mentioned that hydroxychloroquine is also involved at some point for DLE and SLE, of course, as a rheumatologist, we want to ask you. Everybody is very concerned about the pigmentation that starts to come on all of a sudden. You've gone a couple of shades, sometimes
Dark.
darker or sometimes palerish, like you said, that ash shade, and it really bothers patients. Can you tell us why that happens? Is it
It's
avoidable? And if it is not avoidable, why we still need to continue it? Because we have seen patients stop that course of HCQ when they realize that it is because of that the discoloration is happening.
It doesn't happen in everybody. Some color change will happen in everybody. Okay, the classic HCQ-induced pigmentation that we are talking about, that ash gray, does not happen in everybody, and we don't know the reason why. Why? Why is this happening? It is happening because the drug is getting deposited under the skin in your melanin secreting cells. Okay, on your keratinocytes, what we call. So it is getting deposited in your skin, and it is visible outside. That's it. And it has got something to do with photo exposure also, sun exposure. So being very regular with your sunscreens to some extent protects you from tanning. Yeah. So so we don't know how to avoid it completely, but I have seen it get reversed once we stop. That is also there.
Oh,
Yeah.
okay.
Having said this, should lupus people stop hydroxychloroquine because they have all this? Uh, so this is unfortunately one drug which pharmaceutical companies have not come up with a replacement for. You know, if you look at the evolution of hydroxychloroquine, it was chloroquine initially. Chloroquine was given about maybe 30 years, 25 years ago. Chloroquine would be the drug of choice. That has evolved into hydroxychloroquine, which is way more safer. We know that hydroxychloroquine is one drug that prevents you from or protects you from getting diabetes, protects you from some infections, protects you from getting organ damage, protects you from flares. So these
Right.
are all the benefits of having hydroxychloroquine in SLE.
Yes.
Having said that, should everybody take it? If you ask me, yes, everybody should take it. And in India, at least we prescribe it universally. In
Right,
the
doctor.
West, even if you see now, the current data will say about 60% was on hydroxychloroquine, 70% were on hydroxychloroquine. Yeah, so that becomes a factor. But in India, most 85 to 90% of them are on hydroxychloroquine for lupus.
Right,
Okay.
doctor.
So we don't know if we can try drug holidays in between, and we can. These are all really interesting questions to be answered. Can we really pull them off when they are with on high dose immunosuppression? Can we pull them off hydroxychloroquine and wait? You know, so that later on we add on. We don't know. No, nobody knows. But these are really interesting questions that need to be answered so that everybody with lupus can benefit and take it for a long time. Our goal is to increase the longevity of hydroxychloroquine. How do we do that? By probably giving some drug holidays in between and stuff like that, which can kind of reverse the pigmentation and then get back to it again.
Okay, doctor. We talk about flare-ups in SLE. Is flare-up a thing in DLE? Is there a flare-up
Yeah.
equivalent in
Yeah.
DLE?
Yeah. Yeah. DLEs also can flare. New lesions can come. That is a flare. Lesion that has not yet become atrophic again when exposed to UV light can again become erythematous red and start aching. That is another flare. So DLEs can flare. And
Yes, doctor. Okay, I think you're getting a call. No
no, no, no.
worries. Yes.
So DLE that are flaring are probably more going to become SLEs. So that has to be always remembered. If somebody has only DLE and has repeated flares, we should be a little careful that it might be turning into a full-blown lupus and go to a rheumatologist as fast as possible.
Yes, forgive me. I ended up getting a call, but yes, I could hear you, doctor. Uh, Finally, doctor, you did mention that at a later stage, at a highly active stage of DLE, especially when it goes to the scarring stage, you mentioned that biologics are as well an option,
Yeah,
right?
yeah.
At what point should, because patients want to know if they are not being prescribed it and whether they should ask their doctors for it, considering the fact that sometimes it's too expensive to even bring that in. Uh, into the equation. So, should DLE patients with active to scarring nature of DLE get consider biologics as an option?
If it is diffuse DLE, they can consider. Unfortunately, we don't have it in India, so that is going to make it way more expensive to import and give. Yeah.
Right.
So only for DLE will your rheumatologist give you a biologic? I don't think so. I don't think so because of the cost and the risks that we take while giving biologics are massive. You know, we all know biologics, though they are fantastic, they have their own risk. They have their own baggage that comes along,
Yes.
which might be even lifetime. Those problems might linger on even after your lupus is gone. So for DLE, I would still recommend talking to your doctor and context based. If you have a DLE scar somewhere behind your head, you just forget it. You know, grow your hair and forget it. if you have it somewhere visible, which we can do something about it and make things better for you. So it has to be a context-based treatment.
Sure.
You know, it cannot be generalized to everybody. Um, but usually these biologics are prescribed when there are other rashes are also that are cropping up, especially in the case of SLE. So
Okay.
not for a pure DLE.
Sure, doctor. Lastly, as much as I know, the skin, sometimes for patients to know the difference between, oh, it is because of SLE or DLE, or is it because of drugs, we may not have the skill or ability to distinguish, even if we are taught that there is this convenient path that we take, which is to sometimes just blame the drugs. Once in a while we want to throw ourselves a pity party and say it's all because of the drugs. So how do we there's one more part that shows on the skin, which is steroid, which is which but I think what needs to be understood that is that steroids don't cause scars, or they can, right? They can cause stretch marks, but they don't cause lupus mimicking scars in any way, right? Steroids usually.
Yes, right,
Right.
right. They can cause ecchymosis, that might look like a vasculitis. Uh,
Oh,
Easy bruisability and easy bleeding, which might look like vasculitis lesions.
okay.
But usually lupus can, when we withdraw steroids, there can be something called a paniculitis that happens, steroid paniculitis. Very rare,
Okay.
not often. So this can also mimic some of the lupus non-specific rashes called erythema nodosum. So wherever there is a lot of fat, thigh, cheek, and all, it can become a little hard and painful, especially when steroids are being withdrawn. Uh,
Oh,
so, so similar rashes can be seen with lupus as well. So now it becomes important for us to distinguish if it is lupus because of lupus or because of withdrawing steroids. So other than these two, I can't think of anything off my
anything else
head.
that
Yeah,
steroids cause per
yeah,
se? Okay.
yes.
So I think that's mostly the set of questions. Like I think we really want to reiterate it to all our patients that if you have DLE, that doesn't mean you have SLE. But
75% of the times you won't develop,
right, that's good
75%.
news.
Yeah.
Right. But if you have SLE, there's a decent probability of you having DLE,
DLE.
right?
Yes,
Correct,
yes.
doctor. So some of the procedures that were mentioned was, like you mentioned, that skin tattooing for the pigmentation, this removal, the grafting, etc.
Yeah.
That was there. When SLE patients already have, say, an organ involvement and then are on aggressive immunosuppression with maybe sometimes a biologic, is it is it okay for them to even consider these options of, like, say, grafting or tattooing, because doesn't that increase the susceptibility to infections, or is it fine?
You're right. So it definitely increases susceptibility to infection.
Yeah.
So that's what, see, when it comes to cosmetics, yeah,
Yeah.
it is context based always. It's always context based. Are you ready for it? Is the first question in terms of your health. Yeah. Having said that, not everything will predispose you to infections. You know,
Okay.
if done by somebody, if it's done at a dermatologist clinic, probably it will not be. Whereas if you get it done at a tattoo studio, you might, get those
Right.
infections. Yeah. You might want to make that distinction as to who would be the care provider and what is the kind that you can take up. So when there is a really florid lupus going on, we usually say the first 3 months of SLE, we are really not concerned about these things at that time as a physician. Yeah.
Right.
What I want is your lupus under control. And the good news is most of your active DLE lesions might vanish because of this. Yeah, it
Right.
might not go into that scarring phase. That is also there. So when we are treating you aggressively with systemic immunosuppression. But all these concerns will start once we are done with this active aggressive phase and we move into, normalizing our lives. That is when all these things matter. And that is when the discussion with your rheumatologist and the provider for the cosmetic procedure, that is where it becomes very important. Yeah.
My sincere request to everybody watching, especially our warriors, would be that please don't two-time a doctor. So if you are seeing a rheumatologist and you feel like your rheumatologist is not prioritizing your scars, you should understand why that
Yes.
is not a priority. And if it is still bothering you, discuss with them, and please don't go behind their back, meet a dermatologist, not give context, or like doctor said, going to a tattoo studio and getting these things done can really cost us a lot more. So yes, okay, so now we will take a few questions, doctor,
Yep.
and then hopefully in 10 minutes we will wrap up. So to just quickly one question was about the steroid skin thinning, which I think it's called paper skin, if I'm not wrong. Is
The
that a
skin thinning.
okay?
Cigarette paper scars are generally described for vasculitis, post-vasculitis scar.
Okay,
But yeah, skin thinning. Let us keep it as thinning of skin.
okay,
Yeah.
okay. Is that something that can be? Is it like a permanent thinning that's going to happen, or will it get better at some point?
If you are young, it is going to get better. Yeah. The older you get, things are less likely that it is going to become
And here we
better.
are old is easily what, about 20
Above
or
45.
25?
Above
Okay,
45.
such a
Yeah.
relief. Okay, it's not ready to be called old
Yeah,
yet.
because your skin still has the capacity to regenerate,
Got
no?
it,
Yeah.
doctor. Okay, okay. Then the next question was about, I'm just scrolling through, some of them are repeated. So, DLE lesions premature, or is it a permanent marks go away permanent? That was just already in a way clarified, right? Sayuri, but I think doctor, her question was around, do the chronic DLE lesions, do the marks go away at some point? Well, if it has entered the scarring stage, I'm assuming it.
So there are ways to make it go away. Plastic surgery, microsurgeries. These are ways to make it go away. You can cover it, you know. So we had made some infographics which we can probably
Which
post
I'll
it later.
definitely
Yeah.
post,
Yeah.
and I will also share this document, this little guide that doctor has shared with me, with all of you. So that will also be shared in our support group. Doctor, one more thing: is there any hardcore don'ts for lupus patients that are showing both SLE, DLE, other mala rashes or different kinds? But is there any hardcore things that should absolutely not be done? Like you mentioned, of course, like getting close to even passive smoking or smoking, for example, is an absolute no.
Yes.
Similarly, from a skin health point of view, is there something that should be strictly followed?
UV
I think
protection. UV
sunlight.
protection. Yeah.
Okay, yeah,
And
UV
don't
protection.
change doctors often.
Right, doctor. I
Absolutely.
think if I
Absolutely.
may assume why we say that, I think I also learned that after speaking a lot with rheumatologists, is that we need a considerable amount of time to understand the
Yeah.
patient's
Yeah.
nature of
Yeah.
illness, body type.
Yeah.
Right. Right.
It, even we evolve with you as your condition evolves. Even we tend to evolve and understand what kind of a person, what kind of a lupus your thing is going to get into, and what are the things I can ignore in you, what are the things I can reassure you for, what are the things I have to hit hard. It's a journey for both of us. So if you keep changing, you're restarting the journey every time you change. So that's going to be painful for both.
Thank you for that, doctor. I think when I was a child, I was told the same thing. I remember Dr. Joe Thomas very, very sweetly explaining it to me as to why that can't happen, because we were trying to explain it to other patients as well. And one of the things that I think comes in the way is I thought that means I can't travel or I can't do things. No, what doctor is meaning to say is that emergency care can be given anywhere, anytime. That doesn't mean you stop, you don't go to college or travel, things like that. But when your emergency care is taken care of, your
Hmm.
primary physician has to be that one rheumatologist that at least for a considerable amount of time, if I'm not wrong.
Yes, yes. No, you can take opinions. I'm not denying that,
Right.
your doctor will know everything.
Right.
Nobody can have, no, nobody probably can be like that.
Sure.
You can take opinions, but get back to your doctor, have the confidence to talk to them. You know,
Right, doctor.
it's like going back home. You should feel that feeling whenever you go back to your doctor and you discuss about things.
Right.
Only then can things work out for both of you.
Right.
Otherwise, in a journey with lupus, that's not going to be easy. Otherwise.
Right. For lastly, for patients who are on hydroxychloroquine, since I had a tough time initially the first few years, because I also had that lupus gastritis and all of that.
Mm,
What
mm.
do they do? Because, like you said, it is one drug that is trusted by everyone, right? Like every rheumat
Yeah,
swears by.
yeah, yeah. So luckily, these adverse effects are a little rare, as opposed to a methotrexate gastritis. This is much rarer, so that is a good thing. But having said that, it can happen, and some people feel very giddy after taking hydroxychloroquine because they feel a dip in their blood sugars and all. So this can happen in very sensitive people. So one option is to reduce the dose. The second option is to try and split it up. These are
Oh,
options we should discuss with our rheumatologist. If it's a 200 milligram dose, we can still split it up and see if things work better. Somehow we should try and make it has to be a win-win thing. You should be able to take hydroxychloroquine, and it has to be long. And anything that has to be long cannot be really uncomfortable every day. So it has to be made
right.
comfortable in some way,
Right.
and there are ways to make it, and there are ways maybe you yourself can overcome it eventually. That is also a
That is true.
possibility. Yeah.
That's true.
So you give it enough time, you give it enough thought, you give it enough chance. Treat it like a good friend whom you don't want to lose.
Right. 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 And then there are also, like you said, antacids and other
Yeah,
ways to
yeah,
also.
yeah. Of course, medicines are there. We are not talking about adding things. We are
Right.
talking still about not
Uh,
adding and taking care.
okay. Okay. All right, doctor. So I think we have mostly answered all of these. For DLE patients to prevent a possibility of SLE coming their way, would you suggest them to get an ANA or one of those tests like, annually or
No, no, no. Don't do it annually, because we know that ANA, if it is there, would have come at least 3 or 4 years before the onset of DLE. So there's
okay,
no point in doing after DLE, after having DLE. So
okay,
if you have DLE, you should have had ANA if that was supposed to be your phenotype.
right.
Yeah.
Okay, doctor. Thank you very much.
Thank you so much.
Thank you so much, Doctor. Have a lovely Sunday. And thank you everyone for joining. The recording will be posted soon. And we're hoping Dr. Chengappa will be doing more of these sessions with us. And yes, see
Yeah,
you
I
all.
hope I can get to do more of rheumatology sessions than dermatology. This was definitely not in my forte, you can say.
Right.
But
No, but Doctor, we
yeah,
haven't heard DLE from rheumatologists, so we thought it was really important getting that from
yeah.
you.
So you
Thank you.
decided to put me on spot. Thank you so much. It was an honor.
Thank you.
Yeah.
Thank
Thank
you. And see you
you.
soon, Doctor, for
Yeah,
another
sure.
session. Thank you.
So thank you.
Good day.